Okay, sorry for the delay. So, cataract is the most frequent visual impairment complication of uveitis, and it occurs in 64% of uveitis. The cause of cataract is either the inherent inflammatory process, chronic steroid therapy, or age-related change. The management of cataract is a challenge because of its less predictable post-operative outcome. And for the first step, determine the cause and type of uveitis and treat the cause. Now, because of the novel surgical techniques, pharmaceutical technology, perioperative control of inflammation, and biocompatible IOLs, prognosis has improved a lot. The evaluation of cataract in uveitis can be divided into 3 stages: preoperative evaluation, intraoperative considerations, and postoperative management. Visual potential assessment is before surgery is very important, and patient should get a realistic expectation by giving proper counseling. Reason for surgery: visual rehabilitation versus posterior segment visualization. Expected outcome: prolonged follow-up need, inherent need for perioperative medication. If additional procedures like Prasanna vitrectomy if needed, has to be given proper counseling. Preoperative evaluation: if the visual acuity is very poor, potential acuity-meter or laser interferometry or focal cone ERG should be done, and B scan, ultrasound, biomicroscopy, etc. should be done in appropriate cases. Visual prognosis depends on the rate of inflammatory sequelae, and which varies with uveitic entities. Fuchs has best visual prognosis, JA has the worst. The preoperative assessment: anterior segment should be examined for posterior synechiae, peripheral anterior synechiae, inflammatory membrane, myotic pupil, band keratopathy, shallow anterior chamber, etc. Need for a pupil expansion device if needed should be assessed preoperatively. Posterior segment also should be examined for optic nerve, macula, and retina. The indications for cataract surgery: according to Rogers and Foster, they describe 4 settings in which you do cataract surgery. One is visually significant cataract with good visual potential, posterior segment examination, and posterior segment surgery. Patients need posterior segment surgery, phacoantigenic uveitis, and with other intraocular surgery like Prasanna vitrectomy or glaucoma procedures. Timing of surgery is very important. A quiescent period of 3 months should be necessary for getting good visual prognosis, as well as less risk of inflammation and less risk of cystoid macular edema. If you do cataract surgery in active uveitis only in 2 conditions, where that is phacoantigenic uveitis and urgent VR surgery is needed. The success of cataract surgery is depends on the meticulous control of inflammation preoperatively and control of systemic disease. The infectious uveitis like in tuberculosis, syphilis, etc. should be treated preoperatively, and in antiviral drugs should be given in herpetic uveitis. Preoperative inflammation can be controlled by steroids, biological agents, steroid-sparing immunosuppressive agents. The steroids should be started considering the patient's health status and comorbidities. Postoperative tapering should be based on the individualized response of the patient and based on the degree of inflammation. Steroids, most common protocol, either oral prednisolone 0.5 to 1 milligram per kilogram per day, 2 weeks prior to surgery, with slow tapering with augmented topical steroids 2 days prior to surgery. Or can be oral prednisolone 1 milligram per kilogram 3 days preoperatively. Alternative is IV methylprednisolone, intravitreal triamcinolone, intravitreal dexa implants, etc. can be used. Other steroids dosage are either intravitreal, intracameral, or subtenon triamcinolone, intravitreal dexamethasone, subconjugated dexamethasone, or oral prednisolone. Steroids are mandatory in only few conditions, where that is JAA, BKH, sympathetic ophthalmitis, pan uveitis, HLA-B27 anterior uveitis, intermediate uveitis, aggressive or recurrent. Anesthesia is based on multiple factors on one surgeon's preference, facilities available in the center, presence of structural abnormalities. Most of the cases, either peribulbar block or retrobulbar block is ideal because most of the patient need iris manipulation, so topical anesthesia should be avoided. Phacoemulsification is the ideal surgery. Clear cornea phaco with intraocular lens implantation is a standard of care. Advantage is smaller incision, less manipulation of iris and less postoperative inflammation and superior AC stability. ECC can be safer surgery in patients with structural abnormalities like corneal opacity, low endothelial cell count, with a denser cataract and severe zonulopathy. Comparable visual outcome for both phaco and SACS by Bhargava et al. With considering the visual prognosis and endothelial cell count. Pupils, 1/3 of the patients, uveitis patients will have a small pupil, so that represents a difficult surgical technique, higher rate of additional intraoperative maneuvers. Meiosis can be managed by either mechanical stretching, viscomydriasis. Here you can see mechanical stretching followed by viscomydriasis, finally doing sphincterotomy. And even flexible iris retractors can be used. Sphincterotomy is, this is sphincterotomy. So even though the pupil becomes irregular, but your surgery becomes more easier. This is iris hooks. Place you should not stretch the pupil too much so that it can cause irreversible damage to the sphincters. So posterior synechia can break with viscoelastic or cyclodialysis spatula, or you can use a 27 gauge cannula sweep under the iris. And additionally, intracameral preservative free xylocaine with adrenaline. Even peripheral idectomy can be occasionally used if synechia cannot be broken. And then finally, you can introduce another instrument under that and separate the synechia. So capsulorhexis is continuous curvilinear capsulorhexis is the preferred one, sufficiently large enough to cover the optic of the IOL. So the ideal one is more than 5 millimeters size, so that prevents synechia formation, and even 5 millimeter reduces anterior capsular phimosis also. So meticulous cortical cleanup is very important to avoid potentially pro-inflammatory material. IOL should be placed in the back. That is the preferred practice by the uveitic specialist. Minimizes the contact of the lens with the iris and ciliary body and thus reduces inflammation. So biometry is most of the time it will be a challenge because of the altered keratometry reading, altered AC depth and axial length because of band keratopathy, posterior synechia, hypotonia, cysto and macular edema. Contraindication for placing IOL in high risk uveitis only. That is active uveitis despite maximum medication, rubeosis, hypotony, indeterminate cause of the inflammation, previous IOL related complications. So selection of IOL is superior visual acuity of in IOL recipients by a meta-analysis by Mehta et al. Previously it was most of the patients where IOL was deferred, and this study showed IOL will be more advantageous for patients with uveitis. Acrylic hydrophobic heparin surface modified PMMA lenses are the more suitable ones. Multifocal IOL should not be placed because of concurrent retinal disease and later glaucoma. IOL trial, a large multinational prospective study based on different IOLs. Post-operative outcome with these hydrophobic lenses, silicone IOL, PMMA lenses showed all groups have an improved vision, but acrylic lenses have least post-operative inflammation. Silicone group has highest inflammation and increased rate of PCO. So this is 20/40 vision or better post-operative vision and posterior capsular opacification according to the type of lens. Acrylic is PMMA followed by acrylic is better in vision. The postoperative management, periocular or intravitreal corticosteroids, postoperative immunomodulation should be continued. Use of topical corticosteroids slowly taper depending on the inflammation. Then already started systemic steroids should be tapered based on the inflammation, and frequent reviews and monitor for cystoid macular edema. So conclusion, surgery in cataract surgery in uveitis patients is complex. Stay calm and expect the unexpected. Wait for a period of documented quiescence of 3 months. Give perioperative steroids. Don't use topical anesthesia alone. Prepare for intraoperative complications. Place a 3-piece monofocal IOL. Remember, the end of the surgery is not the end of the story. Careful monitoring is important as complications can be unpredictable and occur later than expected. Thank you.